everybody see my screen? Okay. Okay, so I would like to talk about the topic of patients with palpitation and syncope. So this will be entirely case-based. We'll discuss several cases. So I will need some of you to discuss the case with me, so to make it more interactive. What I'm going to do is that I will randomly ask some of the students here to discuss the case with me, so with the mic unmuted. So let's go to the first case. Let's take a look at this ECG. For each case, there will be a brief one-sentence case history on the top. So this is a 76-year-old female with palpitation, and this is her ECG. Let's take a look first, and then I will ask someone to discuss with me. Or if you volunteer, is also welcome. Okay, Claudia Yip, are you here? Claudia? Not here? Okay. Jonathan Choi, are you here? None of you are here. Okay, who are actually present, please open the mic and discuss with me. Should I assume no one is here? Then we can end the lecture.
I'm here. Okay.
Host. Thank you. Who are you?
I'm Wenxi.
Wenxi. Hi. Thank you. So what do you think this ECG is? Would you like to comment on this ECG?
Yes, on this ECG, the patient is tachycardic and is irregular. So I suspect this is a fast AF.
Mm-hmm.
I cannot find any wave, so yes.
Okay. So what is the heart rate?
The heart rate is approximate to large box, so 300 divided by 2 should be around 150.
Okay, that's good. This patient has very irregular heart rate, right? So so each heart rate, each cardiac interval have slightly different number of large boxes, right, between each cardiac interval. Do you agree? Because of the irregularity. So there's another way to maybe to calculate an average heart rate in patients with atrial fibrillation. Do you know how to do that?
We can take 10 seconds and times it by 6.
All right. So how long is 10 seconds on the ECG? How do you know it's 10 seconds?
I think it's like 50 large boxes.
Right. The easier way to do this is that usually one ECG, a standard 12-lead ECG tracing, is 10 seconds. So you can just count the number of KRAS complex on the whole tracing of one of the leads, the long leads here, throughout the ECG, and then multiplies by 6. Then that is the heart rate, average heart rate. Okay. So from here to here, the end of the ECG is about 10 seconds. Good. So this patient has atrial fibrillation, absent P wave, irregular KRAS complex, and rapid ventricular response. So, full marks, okay, for this question, if it happens in the short question. Okay. Anyone else is here?
I'd like to try.
Hi.
Hello.
Hello.
This is Dennis. Yes.
Oh, Dennis. Okay. Thank you.
Yes.
So, this is a 53-year-old male with palpitation and dyspnea. So, usually each ECG, there are several abnormalities, just like the short questions may encounter in the final MB examination. Usually each short questions, there is, for example, one ECG who asks you what are the abnormalities. So usually each abnormality carries maybe half a mark, 1 mark, and there may be multiple abnormalities on one ECG in the short question. So just similarly on this ECG, there are probably several abnormalities. So maybe you can try to pick them up. Of course, there are some abnormalities as the primary abnormalities that probably carry more marks and clinically more important as well. Okay.
I think I can't see the P wave very well.
Okay.
It looks like to me that the QRS is widened. And I think this may be a ventricular tachycardia.
Okay.
Yes.
And, okay. Why? Because you know are there any differential diagnoses in the patients with Y complex tachycardia?
Y complex. It can also be a ventricular fibrillation, for example.
Okay, it can be a ventricular fibrillation, but ventricular fibrillation should be regular or irregular?
Irregular.
Okay, and chaotic, right?
Yes.
So does this ECG look?
No, it doesn't quite look chaotic. It looks regular. For example, it lead to I'm sorry, I can't quite hear.
I think there's something wrong with the mic. I can't quite hear too.
Can you hear me now? Okay, can you hear me now?
Yes, now, yes.
Okay, thank you. So, are there any other differential diagnoses for a Y complex tachycardia?
Why?
Tachycardia with an accessory pathway or bundle branch block.
Right. Supraventricular tachycardia with an aberrant conduction, like a bundle branch block, right, would be a differential diagnosis of Y complex tachycardia. So, do you think this patient may have a supraventricular tachycardia with an aberrant conduction? So look at this part, the whole ECG. So it does not look exactly the same here in the earlier part versus the later part, right? And look at these KRAS complex.
Yes, it becomes more. It is narrower towards the end of the lead. Towards the end of the film. Yeah.
Right, and towards the end of the film, what's another difference? Compared to the earlier part here.
The heart rate is decreased.
Excellent. So when the heart rate decreases and the KRAS becomes narrowed, does that ring a bell?
This may be a supraventricular tachycardia, I think, maybe.
Very good.
With a aberrant conduction, which spontaneously abort later.
Very good. So when the heart rate becomes lower, the refractory period of the bundle branches or of the conduction system also allow better conduction of the electricity. Therefore, the Keras complex becomes narrower. And therefore, this looks like, and later you are right that the SVT aborted, and there is conduction through the AV node, and the Keras complex becomes normal. So it shows that this patient has a possibly changing conduction through the AV node and the Purkinje system that is rate dependent. And look at this part of the ECG. And this part of the ECG. If this is an SVT, then what kind of SVT it is? Look at this shape. What does it look like here? Flutter, atrial flutter. Okay, what shape does it? How do we call this kind of shape? Sawtooth shape. Okay, good. So this is a sawtooth shape, and this is an atrial flutter with a one-to-one conduction, because you can see there each flutter wave is associated with one Keras complex. So this very sharp upright thing here is actually the Keras complex superimposed on the flutter wave. And this in fact is a atrial flutter with one conduction at the beginning of the ECG, and then it later slows down, and you can still see the flutter wave here. And then it becomes a atrial tachycardia. And here you can see the atrial tachycardia is having an AV nodal block with only 3 to 1 conduction. So these are the atrial P wave, the tachycardia wave, but there is only a 3 to 1 conduction of the Keras complex. So this is a atrial flutter and then degenerate into a atrial tachycardia with a 3 to 1 conduction. So the telltale sign here, if you say it is a ventricular tachycardia, I think it's reasonable, but there are obviously other differential diagnoses, and the telltale sign of a sawtooth shape, okay, ECG is that give away the diagnosis. So if you don't think about atrial flutter as a cause, you probably will miss it. But if you think about atrial flutter and then look for a sawtooth sign, then you'll be able to arrive at the diagnosis. And typically, the atrial flutter is conducted in a 2 to 1 conduction. So you will see a supraventricular tachycardia of a heart rate of 150 beats per minute, because the flutter width itself is 300 beats per minute. Always 300 beats per minute. But in this case, it's a 1 to 1 conduction. So very tachycardic. And the answer is atrial flutter with a right bundle branch block, rate dependent, aberrant conduction. So if you can, so each of these probably carries 1 mark, half mark, something like that. So if you can pick up either of these, that would be good. If you said it's Y complex tachycardia, then you may not be able to get any marks in this case. 3 to 1 in the end, can it still be 3 to 1 A flat? Right. So I think you're referring Ho Young asked the question whether at the end can it call a 3 to 1 A flat, atrial flutter, because the shape of the this atrial wave is no longer sawtooth anymore. So I think the diagnosis is atrial tachycardia at the end here rather than a salt, because you should not see a isoelectric baseline if it's purely a sawtooth shaped atrial flutter. But this is a minor point. I think it's a good observation, but because the management of atrial tachycardia and atrial flutter in acute setting is the same, so I think if you say it is a flut or atrial tachycardia, I will give you equal marks. Okay, so here, another patient. 66-year-old male. Anyone want to take this? I think we can just discuss. This doesn't matter if you don't give me the right diagnosis at the very beginning. We should practice how to discuss in the ECG, because in the final MB, in the OSCE station, there is an ECG station. If you don't say anything, you will fail. If you say something, if it's wrong, then we can guide you to the correct diagnosis and you will still be able to pass usually. But if you don't say anything, so you have to practice how to discuss with the examiner. Okay, we're not trying to mark you or trap you, trying to help you. So who wants to take this ECG? A 66-year-old male with prior myocardial infarction and syncope. Anyone? Stephanie, are you here? Stephanie Zhang?
Hello.
Hello, Stephanie. Would you please take this ECG? Describe it. This is a 66-year-old male with prior myocardial infarction and syncope.
So I can see there is widening of the QRS complex.
Okay.
With dominant R wave in V1.
Okay.
So there's right bundle branch block, but with left axis deviation.
Okay, so do you think this is a right bundle branch block, right? This Y-class complex. Is that what you mean? Is there any other differential diagnosis for what type of tachycardia is this? Is this a narrow complex or wide complex tachycardia?
A wide complex.
Okay, so in the patient with wide complex tachycardia, apart from right bundle branch block, any other differential diagnosis? Actually, we have just discussed this in the previous case.
It could be a SVT with aberrant conduction or bundle branch block.
Okay, it can be an SVT with aberrant conduction. Right bundle branch block is one kind of aberrant conduction. Okay, so SVT with aberrant conduction is one possibility. Any other possibility for a patient with wide complex tachycardia?
Could be ventricular tachycardia.
Ventricular tachycardia, very good. Is there any telltale sign that can tell you right away whether a ECG like this is a VT or SVT with aberrant conduction? Telltale sign.
Yeah, someone in the chat box says there's capture beat. Oh yeah, I can see there's a capture beat.
Okay, so here you see suddenly a narrow QRS complex that is of different morphology here. So this one and also this one here. So if you once you see this a narrow complex beats amongst patients with amongst of the already wide complex tachycardia, we call it a capture beats. The mechanism. Do you know the mechanism of a capture beats? What is a capture beats? Ho Chuck Young, you mentioned capture beats. Can you explain what is in the capture beats?
is it a normal sinus beat that happens in between the VT?
Right. So let me explain it more clearly. So in the patients with VT, the whole conduction system is driven by the ventricular complex, right? There's a ventricular foci that's keep firing and therefore capturing the whole heart. The sinus node actually is also still functioning, but it's just too slow. It does not capture the heart, so it's kind of buried in all the Y complex. But the sinus node is still firing. So by chance, a sinus node electricity wave can pass through the AV node during the refractory period of the ventricular foci, and then can depolarize the ventricles through his Purkinje system by chance. So every now and then there may be one sinus beat that can actually pass through the AV node and then through his Purkinje system and depolarize the ventricle in a normal way, therefore giving you these sinus beat or capture beats in the middle of the VT. So that's called capture beats. When can you hear me?
It's better now. Yes.
Okay. Sorry. I was explaining the capture beats, because normally because in the VT your SA node is still actually firing, and by chance it can pass the electricity from the SA node can pass through the AV node and then capture the ventricle through his Purkinje system, and therefore giving rise to a normal looking narrow complex. And this is called capture beat. Fusion beat is just a hybrid of a electricity that the ventricle, the VT foci, and the sinus node activity capture the ventricle at the same time. So it's kind of like a fusion beats. So morphologically, it looks intermediate between a narrow complex beat and a Y complex beat. So here, these two here are the capture beats or the fusion beats. This one looks more like a capture beats, and this one look more like a fusion beats. But the essence here, if there is suddenly a narrower QRS complex amongst a chains of ventricular complex, then this Y complex tachycardia is ventricular tachycardia. Okay. So if there's any question, just let me know. Just ask. If not, so this is the answer. This is VT, AV dissociation. Peri-infarction, fractionated conduction means here, some of the QRS complex looks very bizarre with a lot of fraction. It's like being broken down into several pieces. So this sometimes can be seen in a patient with a large myocardial infarction. It's not RBBB, so there's a comment here. It's not RBBB. Yeah, I won't call it RBBB because it just does not fulfill the criteria of a right bundle branch block. You have an RSR prime here. Should be the RBBB. Actually, it is a ventricular tachycardia. It's not a bundle branch block. And the essence here is capture beat. So whenever you see a Y complex tachycardia there are two differential diagnoses: SVT with aberrant conductions versus VT. There is nothing you can tell exactly which is which unless you see the capture beats. If you don't see the capture beats, every other criteria, like the Brugada criteria, whatever criteria, they just give you some educated estimation whether it's VT. They are not gold standard. So I don't think we'll ask you in detail about Brugada criteria or those things. If we want to test whether you know how to differentiate VT or SVT, we'll give you an ECG with capture beats, because all the other things are controversial. Only a capture beats here can be arguably, there's no disagreement that once you see a capture beats, this is a ventricular tachycardia. If you don't see a capture beats, it is either a VT or aberrant conduction, SVT. In terms of management, if the patient is hemodynamically unstable, then we will treat the patient as VT unless proven otherwise. Okay, so this is a 53-year-old male with severe chest pain, loss of consciousness during the ECG. So this is, we would like to pick this. Amanda, hi. Are you here, Amanda?
Yes, hi, I'm here.
Hello, would you like to take this ECG? 53 years old male with severe chest pain and lost consciousness during the ECG. Hello, are you here?
Hello?
Hello, can you hear me? Do you like to
Yes.
take this ECG? Can you
Yes.
comment on this ECG? What do you
Sorry,
see here?
can you hear me?
Yes, I can hear you.
Okay.
Mm-hmm.
It looks like a case of VF.
Right. So this is what we call a chaotic ECG. You don't see any organized activity, unlike the previous one with atrial flutter. So it's like very irregular, and there's no organized electrical activity, not P wave, not KRAS complex. It's just like something that you will see on ECG when you're just shaking your hand when you're connected to ECG. So it is a ECG of ventricular fibrillation. No distinct PQRST, irregular deflection of varying amplitude. So what is the management? Amanda, what is the management in this case?
So the management would be cardioversion.
Cardioversion? What do you know? Do you know what is cardioversion?
Sorry, I mean it should be defibrillation. Sorry.
Defibrillation, because it's a vibration, right? It is a ventricular fibrillation. So you want to defibrillate it. Okay.
Yes.
What is the energy you will use to defibrillate?
200 joules.
200 joules. Okay. 84. Thank you, Amanda. 84-year-old man with loss of consciousness. Lee Chak Yan. Are you here? Lee Chak Yan.
Yes.
Hello.
Yes.
Can you comment on this ECG?
This is a ECG of a 84-year-old male, which shows a irregular rhythm and
And the P wave is not present. And there seems some kind of flutter wave in lead 2 and lead 3.
You mean here, right?
Yes.
Do you mean here? Yes. Okay. So there is sawtooth shape again, flutter wave. Good observation. Anything else? How do you explain the loss of consciousness?
There is a loss of the electrical activity for a period of time from lead 2.
Only lead 2?
Also V1 and V5.
Actually, all the leads. Actually, all the leads, right? So what do you think is the cause of the, what is the rhythm during the absence electrical conduction? Is there any P wave there?
No.
So if there's no P wave, what is the rhythm?
Junctional rhythm.
Do you see any QRS complex?
No.
Do you expect to see QRS complex if there is a junctional beat?
Yes.
Okay, so is it still, do you think, a junctional? If it's a ventricular rhythm, what do you expect to see?
YQRS complex.
Do you see any YQRS complex during the period of no electrical activity? Okay. So what is the rhythm?
I don't know. No rhythm.
No rhythm is something that is not medically correct. So if you see a flat line on the cardiac monitor, how do you call it? You see a flat line, patient cardiac arrest, a flat line on the ECG tracing, how do you call it? Asystole. Very good. Okay, someone answer. Chen Yu Sing answer asystole. Chen Yu Sing, would you like to open your microphone for us?
Hello.
Hello.
Yes.
So excellent. So it's asystole. Thank you. So can you give us a collective summary of this ECG?
Okay.
Just describe this ECG in your own words.
Okay, so this is the ECG of this 84-year-old gentleman with loss of consciousness. I can see that there is narrow QRS complexes in the first part of the ECG, which then recovers after a period of asystole. But after the period of asystole, I think the QRS complex are not regular, and there seem to be skip beats. Also because of the bradycardia, I will also think about heart block maybe. However, the QRS, since the QRS duration is not, since the period between the QRS are not regular, so it may not be complete heart block, but I'm not very sure what it may be here.
Okay, so very good. You point out several important points. This patient has sinus as asystole, or sometimes in the patient who actually still have a heartbeat, they're not in cardiac arrest, so we don't call it actually asystole, because asystole also implies the patient does not have a heartbeat, is in cardiac arrest. So if the patient is like he's having a pause, we call it sinus arrest, sinus pause or sinus arrest, meaning the sinus node is not firing. So this is a sinus pause or sinus arrest. And this is something you will see in a patient with a sick sinus syndrome. And you see here that it is an atrial flutter in the very beginning. And then actually the last two bits here is a sinus rhythm. You see here there's a P wave, there's another P wave. So there's two sinus beats and then followed by a sinus arrest. There's no sinus rhythm at all. And then no ventricular or junctional escape as well. And here, finally, there is a junctional rhythm. This is a junctional rhythm with no P wave before it, because after the heart has stopped beating for has no sinus arrest for some time, that the AV node will take over. So you have the junctional beat here, and then here there's another sinus beat, but now the patient goes into sinus bradycardia, because you can see here this is a sinus beat, and sinus beat, but the heart rate is very slow, less than 50 beats per minute, and therefore this part is a sinus bradycardia. So atrial flutter, and then sinus arrest, and then sinus bradycardia with a junctional escape here. Okay, so this is the whole thing. But if you can say it is a sinus arrest or even asystole, will give you marks. If you pick up the atrial flutter, will give you marks. But most importantly, if you say it is a heart block, you can't get a mark from heart block, because there's no evidence that there is a delayed or absent conduction of the P wave to the QRS complex. So that the PQRS relationship is 1-to-1. There is no non-conducted P wave or prolonged PR interval to suggest it is a heart block. Therefore, it is not heart block. Okay.
Okay, thank
Any
you.
question? Okay, thank you very much. Okay, we'll just go on. A 63-year-old female with cancer, hypotension, and near syncope. Sometimes we have syncope or palpitation or hypertension not necessarily related to rhythm abnormalities, but there are still some hints on ECG that can give clues about the underlying cause of the syncope. Anyone? Okay, Wingzy, you mentioned electrical alternance. Would you like to describe this ECG?
I think I can see some electrical alternance in the V1 lead.
Okay, here you see, right, okay.
Yes, and also the V5, the long V5. So since the patient have cancer, so I suspect there is some pericardial effusion due to cancer seeding.
Can you explain to us what is electrical alternance?
Is when the heartbeat it swings in the sac of fluid, causing a different electrical axis every time it beats. So it's like alternately changing the axis.
So how do you diagnose electrical alternance on the ECG?
When there is like one large, one small, and then one large and one small.
Right. So when there's changing, alternating amplitude of the QRS complex, or changing, alternating axis direction of the QRS complex, then the diagnosis is electrical alternance, and differential diagnosis of electrical alternance is cardiac tamponade. So the underlying mechanism of electrical alternance, as Wingzy said accurately, because when there is a large amount of pericardial effusion, the heart swing in the pericardial cavity like this. So the heart swing in the pericardial cavity, and then it will change the axis amplitude or axis direction, and therefore on the ECG it will show that electrical alternance. Okay, very good. So this one is electrical alternance. This may be the final case. A 37-year-old male with a history of syncope, but it's asymptomatic currently. Marcus Chung, are you here?
Hello.
Hello. Would you kindly help us to describe this ECG for us? Asymptomatic male, currently symptomatic, but history of syncope.
So just beginning, this patient has a regular heart rate with at about 75 beats per minute.
Mm-hmm.
These no axis deviation. But there's
You mentioned regular heart rate, so do you mean it's just in sinus rhythm or not in sinus rhythm?
sinus rhythm.
Okay.
There's some abnormalities of over V1 to V3. Looks suspiciously like right branch block. Sorry, I can't hear you.
Okay. Hear me now?
Yes.
So you mentioned the V12 looks like a right bundle branch block, but is it a typical right bundle branch block?
No.
Okay. What is the abnormality? What is the characteristics of this KRAS complex that makes you think it is not a typical right bundle branch block? So how about the ST segments? Do you see any abnormality in the ST segment?
Over the V3 ST segment is elevated and
okay, good.
concave.
All right. Okay. Concave. So you mean like this one, right?
Yes.
Okay. So do you have any differential diagnosis in mind?
Could be pericarditis, but then I would expect it to be more diffuse with PR depression. But in this case,
Right.
I didn't see it in the other leads.
Any other features that does not suggest it is a acute pericarditis?
There's no PR.
How about the distribution of the ST elevation?
As I said, it's also not it's not seen in the other leads.
Okay, right. Yeah, it's not diffuse enough, right?
Mm-hmm.
It's not diffusely involving all the other leads, just locally, V1 to 3
Yes.
mainly. So this speaks against pericarditis.
Yes.
Mm-hmm. So does it look like a STEMI?
Not really either, because it's not a very typical STEMI pattern, and usually I would see more of a anatomical pattern, but this is more of an isolated.
In a patient with a STEMI, what is the usually sloping direction of the segment? Is it usually upsloping or downsloping, or flatten or convex or concave? How do this describe a typical ST elevation in the STEMI patient? The ST segment is usually downsloping or upsloping.
It's more flat to upsloping.
Yeah, it's either flat like a plateau or it's upsloping, right? But in this case, is it a downsloping or upsloping?
Downsloping.
Downsloping. So does that ring a bell? Any diagnosis that is associated with that kind of
maybe young gentleman also. Maybe like a Brugada, type 1 Brugada. In the lit V2, downsloping ST segment elevation, or with curved downsloping. Sometimes it looks like a saddle shape here. So once you see a patient with a downsloping ST elevation, think about Brugada syndrome, especially in patient with loss of consciousness. Okay, it's very different from a ST elevation in the patient with STEMI, where you have a flattened or usually upsloping types of ST elevation. Okay, and it looks like a right bundle branch block, but it is not. It's a downsloping ST elevation that give you a an illusion that it is a right bundle branch block, but it's actually a part of the ST segment downsloping. Okay, so I think I will stop here. Is there any questions about any questions? Can you get more easy tutorial exam? Okay, maybe I'll just give you a few more now. I have actually plenty, but if you want more, I can give you several more. Do you want that? Let's go through a few more ECG. Do you want a few more ECG? Other students? Okay. Let's do this one. Okay, I'm trying to open my PowerPoint. It's kind of like, okay. Okay, can you see my slides? Okay, so Berners Pang, since you are the one who asked for more ECG, you should take this one. A 68-year-old male with fatigue and dyspnea.
Hello.
Hello.
So we can see that the patient is rather bradycardia in this case.
Mm-hmm.
And there is it a junctional beat?
Where? Which lead?
wait.
Here, this one?
Yeah.
A junctional beat. Okay. Is it the only junctional beat you see here?
Also earlier in AVR, AVL, AVF.
Okay. Is there any? Okay, so these are junctional beat, right? So oral junctional beats, actually, you don't see any P wave preceding the Keras complex. Okay, so it's a junctional rhythm. And you mentioned it is bradycardia, right?
Mhm.
So what kind of bradycardia is this?
Junctional bradycardia.
Right, yeah, exactly. This was just junctional bradycardia. So you don't see the P wave. So this is all the junctional rhythm. So it's a junctional bradycardia. Okay, you only see the Keras complex, narrow ones, no preceding P wave in all of them, and it's bradycardic. So this is a junctional bradycardia. Excellent. So you get so if it's a 2 marks question, you got 1 mark already. Any other abnormalities?
I'm not too sure.
What is this wave here and here?
So the isoelectric line is it a U wave?
Why do you think it's a U wave?
Because it is down sloping, so probably hypokalemia.
No. Why do you think it is a U wave?
Because it's after the T wave.
Yeah, exactly. So it's after the T wave, and it's U wave, PKRSTU, right? It doesn't look like a P wave or whatever. So it's a wave after the T wave. A very large wave, almost looks like the T wave, but it's after the T wave. So it's a U wave. The best guess is a U wave. So what are the differential diagnoses of U wave?
It could be hypokalemia. It could also be digoxin-induced hypokalemia.
Very good. So this patient actually has hypothermia, all right? So if you see and hypokalemia, what electrolyte disturbance can give you U wave apart from potassium? You're right. It's not hypothermia. It's electrolyte abnormalities, hypokalemia. But what other electrolytes can give you a U wave?
Is it magnesium?
Hypomagnesemia. So in a patient with hypokalemia, U wave, unexplained hypokalemia, especially, check the magnesium. Okay, you need to check the magnesium. Okay, check the magnesium, check the potassium in this patient. Okay.
So do you mean if it is a hypothermia, it can also cause a U wave or junctional escape?
Hypothermia can also present with a U wave, but it's not very specific. There's another ECG abnormalities that is more specific for hypothermia. It's called the Opsborn wave. I will see whether we can but you're actually correct that hypokalemia is the first differential diagnosis in the patient with U wave, and the hypomagnesemia. So think about those two. Okay. Good. This one, who want to take this? And Wang Jihim, do you want to take this? Okay. Mm, very good. Very good. I think you pick up the major diagnosis as a third-degree heart block. What do you think is the R wave progression here? Hmm. So normally the RA progression is there is a usually a predominant S in V1 and then predominant R in V6, and there's a transition where R and S wave are equals in V3 and V4. That's normal, right? There's a gradual change from the negative to a positive, KRS from V1 to V6. But here you can see that V1 is negative and V2 is positive. But V2, 3, and V again, it becomes the positive, and it becomes a neutral, which is unusual, no matter what kind of pathology it is. So, what do you think might explain it? Suddenly, this kind of jumping polarity of the KRAS complex, from negative to positive to again neutral, and then negative, and then negative. Okay, there's anyone else? Anyone want to make a guess? Wrongly placement, yes. So probably wrongly placement. Otherwise, you shouldn't see something like this. You either see a very poor R wave progression, so almost all the leads are negative. There's no transition, or you can see a early transition with a dominant R wave. So poor R wave progression may be due to myocardial infarction, as you mentioned, maybe due to dextrocardia, and the dominant R wave can be due to posterior myocardial infarction or pulmonary embolism or right ventricular hypertrophy. But you see something like this jumpy kind of axis. It's not natural. It's usually due to wrong lead placement. So someone has mixed up probably V2 and V6 or other leads as well. So to give you this, so this is a wrong lead placement. It's just a minor point. You have picked up the most important thing which is the third degree heart block. Very good. Another abnormality is actually also present here, which is not artificial. Can you comment on the AVL? Anyone can? Yes? Mm-hmm. What about with amplitude? Very high. Okay. What does it suggest? High amplitude, tall amplitude in AVL. How many volt is there? Millivolt. How many small square there? Okay, excellent. What do you think is the diagnosis? Why do you think it's not hypertrophy? It could be. Jeffrey Chan, you asked whether it's hypertrophy. Do you like to comment on this ECG? Jeffrey Chan.
Can you hear me?
Yes.
It might not be a hypertrophy because it's quite isolated.
Mm.
And,
Right. So, what kind of ECG criteria you know for diagnosing LVH?
Sokolov as well as
Sokolow's criteria. Okay, everyone knows that. Can you explain what is Sokolow's criteria?
so that will be an increase in the we will look at V2 and V5 if the R wave of the V2 as well as the S wave of the V5 adds up to be higher than 35 millivolt, and that will be constituted as a.
Are you sure it's V? Are you sure it is the R wave of V2?
Sorry. It's the S wave of P2.
S wave of P2 and P1 actually, whichever is larger, plus the V65, whichever is larger, having a larger R wave. Then if it's more than 7 R square, it is LVH. That's Sokolow's criteria. There's another voltage criteria called modified Cornell's criteria. We'll look at the AVR only, because the LVH can sometimes, they at different parts of the LV can give you different leads increase in the voltage. So there's a Cornell's criteria. When the Sokolow's criteria is negative, the Cornell's criteria may still suggest LVH in some patient. So if it's more than 12 millivolt, 12 small square in the AVL R wave, then it is LVH. Plus, this patient has also left axis deviation. Okay, you look at the axis, it's left axis deviation because lead 1 is positive, lead AVL is negative, and lead 2 is also negative. So it is a left axis deviation plus the high voltage in the AVL is diagnostic of left ventricular hypertrophy. So this patient also have LVH. Okay. This one. Carol Lee.
Hello, Professor.
Okay, hello. What do you think? This one, a 76-year-old asymptomatic female.
Maybe I'll go step by step.
Okay.
So, first of all, the patient has, I think, rather irregular heartbeat, and for the P wave, is sometimes not quite observable, but sometimes I can see there is some sawtooth morphology. I think the patient can have either atrial fibrillation or can be also multifocal atrial tachycardia.
Okay, your differential diagnosis is AF versus MAT. Which one is more likely?
So for MAT, the definition is we have to find P wave with different morphology. So I think we can see different morphologies of P wave, so it can be MAT.
Do you think MAT is more likely or AF more likely? Where is the different morphology P wave? You mean here?
I'm just thinking sometimes I'm looking at the lead 2. So
2, okay.
Yeah, I think sometimes the P wave is not that obvious, but sometimes it has a more sawtooth like appearance. So I thought it's a different morphology, but I'm not so sure.
Mhm. So you mean so there's no P wave here, right? Agree? There's no P wave here. So there's some waves here. Is it consistent with a P wave, a organized waveform preceding the Keras complex?
Not very organized.
Not very organized. What is it then? If
Is
it's
it
not very
atrial
organized,
fibrillation?
it's a fibrillation wave. All right, these are AFib waves, undulating. So the term is undulating baseline on the ECG. Undulating means wavy, but is not very organized. It's not sawtooth. Sawtooth is very organized, like triangular sawtooth shape.
Okay.
It's undulating. The word is just 震下震下. Okay, so this is fibrillation waves. All right. So fibrillation waves, not P wave, and irregular Keras complex. Okay, so the diagnosis, one of the diagnoses here is atrial fibrillation. Okay, so what else do you notice on this ECG? What is this?
Is a Q wave
Okay, it's a Q wave.
and also some tall T wave.
Okay, tall T wave. What is this?
Maybe pacemaker spikes.
Okay, pacemaker spike. Okay, so this is how we go in exam, right? Like we usually, if we will point towards something, usually a larger area, if you still can't recognize it, we'll point to a smaller one. So if you mention this pacemaker spike, then I can give you no further clue. Okay, can you hear me?
Yeah, I can hear you now.
Okay, so if I point towards this, then you have to tell me this is pacemaker. If I point to this, you still can't figure out it's pacemaker, then there's no more additional clue I can give. Then you probably pass that. I cannot. Okay, so good that you pick up is a is a pacemaker spike. Good. So is the pacemaker function normal on this ECG? Do you think the pacemaker function is normal?
I think not, because
Why?
Because the patient still has like irregular heartbeat.
What's the function of a pacemaker?
To regulate the heartbeat.
So this patient is asymptomatic. Do you think that the pacemaker function is not regulating the heartbeat in this patient?
Okay, then probably the pacemaker is working fine.
Okay. So if you have a Keras, there's two functions in the pacemaker. One is sensing function and one is the pacing function. And on the ECG, you can evaluate both functions. For the pacing function, it means that when the pacemaker fire, then it will capture the chamber. Usually is the ventricular chamber in this case, then there will be a ventricular depolarization. If it's a atrial lead, then there will be a P wave after the pacemaker spike. So if there is a Keras complex after the pacemaker spikes, after each of these pacemaker spikes, then the pacing function is normal.
Okay.
On the ECG. Another function is sensing function, which means that when the patient's heart rate is fast enough, then the pacemaker should not do anything. They should not pace when the patient's heart rate is fast enough. Okay, so if, for example, if there is a pacemaker spike, suddenly you will see when the heart rate is more than 60 beats per minute. Of course, this 60 beats per minute is something we can change in a pacemaker setting, but normally we'll set 60 beats per minute as the pacing rate for most of the pacemaker. Okay, so if you see a patient having a heart rate more than 60 beats per minute, but if the pacemaker is not sensing normally, then you will see a pacemaker spike somewhere during the heartbeat. For example, you see the pacemaker here and here. So every in the 60 beat per minute interval, the pacemaker will pace. But here, when the patient intrinsic rhythm happens, the pacemaker does not pace. There's no pacemaker spike before or around this ventricular beat because the pacemaker is sensing the patient's own intrinsic ventricular rhythm. Therefore, the pacemaker is sensing normally also on this ECG. Did I make myself clear?
Okay, yes.
Okay. So if you see another pacemaker spike here on top of the normal QRS complex, then the pacemaker is not sensing normally. It's called undersensing.
Okay.
And usually the threshold is 60 beats per minute, but you can also judge from the own pacemaker spike rate. So pacemaker spike here and here and here, and it doesn't occur here because it's sensing this beat, which is an intrinsic beat. So the sensing function is normal. And the pacing function is normal because the pacing, after the pacemaker spike, there is a QRS complex. If you see a pacing spike, nothing after that, then it may be a malfunction in the pacing. Okay. Don't go to this one. Okay. Okay. Okay, this one. Who want to take this one? 76-year-old female bound and responsive in elder home during winter. It's probably you will see this ECG now in the A&E department in the outdoor where our poor COVID patients waiting in the cold weather. Wing-Chi, are you here? Still here?
Yes, I'm still here.
Okay. Would you mind take this ECG?
Yes. So the thing is the Osborne wave in V456 that you just mentioned, a feature of hypothermia.
Okay, sorry, my connection wasn't very good. Can you repeat again?
The Osborne wave in the V456 is a feature of hypothermia that you just mentioned.
Very good. So you see here in the J point here, which is the end of the QRS complex, you see another wave. So sometimes it's called the J wave. The J point is where the QRS complex turns to become the anti-segment, the junction. That's why it's called J point. And if you see another small wave there, then it is called a J wave, or as Wing-Chi said, Osborne wave, and it is classical for hypothermia. Okay, so I think that's we should stop here. Any questions? Okay, if no, thank you very much, and we'll see whether we have another occasion to discuss more ECG before the exam. Okay, thank you very much for your kind attention. Okay, have a nice day.